Community conference. Yes. All right. We have about 30 speakers who are contributing their time to bring the X and Y chromosome variation community up to date on research findings and treatment advances, and they prepared numerous presentations for you. Also built into the schedule, we have a number of sessions where you can meet others, sharing particular genetics signatures, lots of opportunities to socialize. And we have 2 panel discussions where those with lived experience can offer their views on both disclosing the diagnosis as well as being adults who are going to tell us what it's like to live with a genetic condition. We could not put on these conferences without the financial support of our sponsors. AXYS, which was one of the former organizations that merged with KSNA, provided a platinum sponsorship. The National Institute of Mental Health, which has been conducting X and Y chromosome variation research since the 90s, is a gold sponsor. We also have the XXYY Project, Natera, the Scotto Family, and my publication, which is Supplemental Needs, a novel about prenatal diagnosis. They're all silver sponsors. Chromodiversity Foundation is our sponsor of kids and teens activities today. They're conducting the Chromodiversity experience over in Wisteria Lanes with a number of our young people. Lindsay Lind, our program director, is standing at the back of the, she has done yeoman's duty with all of the details. Rick Frith, our communications manager, is up in the booth. So I also want to thank our board members and the many volunteers without which this conference could not take place. You're going to be hearing from the medical directors and researchers at the ACRC, which is the AXYS Clinic and Research Consortium network, about the progress that they've made in providing specialized education and treatment for those with X and Y chromosome variations. This network started at Children's Colorado. You'll also hear in this keynote from Shanlee Davis, the project director for the, which is a database that provides high quality research data on the medical, educational, and psychosocial issues characteristic of the population. If you haven't already enrolled, Dr. Davis and her research team will be able to tell you more information about Galaxy and help you with obtaining consent at their exhibit table in the hall. This is also directing, along with Dr. Klaus Gravholt of Denmark, the first comprehensive set of clinical guidelines for diagnosis and treatment of Klinefelter syndrome. These will be followed by additional guidelines for the other variations, including trisomy X and 47XYY. I felt so strongly about the importance of supporting this project financially that we offered to match all funds that are donated up to a total of $10,000. Yeah. And the matching fund has been very successful, and we've already exceeded. We're looking to collect a bit more in the way of donations. So we'll be taking donations at the table outside the auditorium. And for a $20 donation, you can either get an AXYS blanket, or they will give you a copy of one of my books, which is Living with Klinefelter Syndrome, Trisomy X, and XYY, or the novel that I wrote, which is Supplemental Needs. So we hope that you will stop out there and provide a donation on you, give you something in return. Okay. All right. I have 2.
How about I do the same? What you just did.
Okay. Okay. I'll talk with you. I'll talk with you later about setting up campaign. I have two housekeeping issues. Though only the sessions that are given in this room are recorded. However, we're asking the other speakers in the breakout rooms if they would share their slides with us, and then we will post them on the website. Okay. Another error that I have to apologize for is that the program said that breakfast would be in the dining room. In fact, continental breakfast is in this area, in the conference area. Now I would like to introduce Cheryl Kelly, AXYS's Executive Director Emeritus, to speak about the ACRC network.
Good morning, everyone. Just let me know if you can't hear me or understand my pronunciation of anything. I want to welcome everybody here. I was here at the 2019 conference, and I can't believe it's been 6 years since we've been able to get together in person. We appreciate each and every one of you, and especially our medical professionals, our researchers, just wonderful, and our speakers, just wonderful, wonderful folks. So I want to...
I just have to interrupt. I need to have somebody come up here and just show us how to advance the slides.
Here comes Gail.
Oh, here comes Gail.
Gail has it. So the ACRC, which is the acronym for the AXYS Clinic and Research Consortium, was started in 2015 at the University of Colorado, as Ginny said. We now have 20 multidisciplinary and 3 single specialty clinics. 17 of the clinics are in the United States, 2 are in Denmark, and 1 is in the UK. So to find these, and the multidisciplinary clinics means that they don't see just urology or just endocrinology. They will have a team of specialists that will see you. The way to find the clinic, www.org, scroll down and there's a button and it says clinics, and you just click on that. One thing I wanted to highlight is AXYS has for several years, and we're continuing to do this. We offer up to 10 stipend, $20,000 a year. It's up to $500, and it's for reimbursement for travel expenses. It doesn't cover testing or doctor appointments, but it covers things like transportation, hotel, and meals. Currently, what you need to do, the process is you go on our website, you fill out the application form, and very quickly you'll get an email back from AXYS that says, congratulations. Once you've seen the doctor, here's the expense reimbursement form you need to fill out, and we need copies of receipts, and you submit that, and we're pretty quick turning around with the check. So I just wanted everybody to know that. So the ACRC these are the and treatment. In October of this year is going to be the 4th International Workshop on Klinefelter syndrome and other supernumerary sex chromosome aneuploidies. So it's my understanding, and it covers, in addition to 47XXY, 47XYY, and trisomy X at this point, but I believe there are plans to expand it. So it's a global effort to bring together clinicians and researchers, and they are working hard on creating evidence-based treatment, clinical treatment plans or recommendations for individuals that have a variation. And in fact, so there's a 9-member international scientific advisory committee for the workshop, and 6 of the 9 members are ACRC members. So it's a wonderful opportunity. And actually, I'm going to be going to the conference to represent AXYS, and hopefully we can expand our reach even further. So we have two co-chairs of the ACRC committee, subcommittee of the board, Dr. Alan is professor emeritus, pediatrics and pharmacology at the University of Virginia. He's retired from his paying job, but he's everywhere. And Dr. Maria Vogliazzi, MD, she's the medical director of Children's Hospital of Philadelphia, which sees patients with Klinefelter syndrome and all other XY variations. And Maria
So the ACRC activities and results, which pretty much runs itself. Maria and I kind of look out over it, but it does a pretty good job. We have meetings with the ACRC members. We did that on Friday.
It was off. Sorry. That will help. All right. So our program is called the Klinefelter Syndrome Program. Patients with additional aneuploidies as well. Primarily, our genetic counselor does a lot more of that than I do, but we are happy to see patients with XYY, XXYY, XXX, all of the above. So I'll first give you a little bit of information about our clinical program. We formally opened this program about 1.5 years ago, but we were seeing a lot of patients prior to that. And I think similar to the experience of most of the other clinical programs, we were seeing more and more new patients every year, and it became very clear that we needed a formal program for this. So this has kind of evolved, and you can see, like in 2020, we had a few patients, and in 2024, this was like the number of visits we were seeing each year, and now overall we have about 200 patients in our program. So our coordinator is Danielle Lee, who is here with me today, and her background is in social work. I'm the pediatric endocrinologist. We have 2 genetic counselors who work with our program. And then we have 2 pediatric urologists and then an adult urologist who also are, I would say, affiliated. We have our once a month, we have one day allotted for this program, and but we've sort of engineered this so our space is physically next to the urologists, the pediatric urologists. So I find that oftentimes when I'm examining an infant, I might say, I think it might be helpful if one of the pediatric urologists were able to take a look too, and then I can just kind of grab them from next door. So we've tried to do that just in terms of proximity to involve our pediatric urologists as needed. We have 2 pediatric psychologists that are associated with our program, and that is Jackie Papadakis and then Zach giving a presentation. And Zach is currently a fellow, but sort of knock on wood, hopefully in a month or so, we'll have signed the contract and be our official pediatric psychologist for our program. And then we work with the neuropsychologists at Lurie, and there are 1 or 2 of them that see most of our patients. And then kind of loosely with developmental pediatrics, even fewer of them than pediatric endocrinologists. And so we can squeeze some people in there, but unfortunately, we don't have a Dr. Tartaglia at Lurie Children's yet. So we have our monthly multidisciplinary program. We do a lot of prenatal consultations now, and so typically that means that I meet with parents along with our genetic counselor. It's usually Allison Weissman, and we do most of those actually by telemedicine now. And so we'll meet with families at that point, and then once an infant and they'll see us in person. And then typically we see children about every 1 to 2 years. And I sort of explain this to families as this is a time where you're going to come and check in. I don't expect to find any health problems, generally speaking, in a 2, 5, 7, 8-year-old. But we're having you come just sort of as a time to check in, to make sure that the developmental evaluation with your pediatrician has been sufficient, that there aren't any questions, are there things that we might need to help refer or help evaluate, and then to let you know if there's anything new, because as we all know, there's a lot of research being done and there's new data and new information all the time. And that way we have a chance to make sure that we're catching everybody along the way. And then starting in adolescence and young adults, I will often be seeing people every. Our research program is growing. So everybody in our clinical team plays some part in our research program. And then we have some additional members of the research team that include one of our endocrinology research manager, Sarayu Ratnam, and one of our coordinators, Luke Lucio. And then we've had a number of genetic counseling students who have done their thesis projects with us. And so a few of them are listed here, Abby and Sophia. And so Abby just published an article here, this Finding Acceptance, How Adolescents and Young Adults with Klinefelter Syndrome Navigate Identity, Disclosure, and Support. So that was very exciting. She's now out in the world as a genetic counselor. And then some ongoing projects. We are part of the Galaxy Registry. I think one of a program that Zach will speak about in a lot more detail tomorrow. But we started this last fall, I guess, in September was our first camp. And the idea was that this is a research project, but also hopefully a useful intervention and fun experience for boys with XXY who were in middle school or high school is kind of who we recruited. And the idea was to have a camp focused on physical activity and improving social skills. And so I'll give you just another minute about that. And then if you it was run by an adaptive PE teacher who helped to run all the physical portion of it. And then our psychologists did social skills portions. And in the first camp, we had invited some of the chromodiversity team. That was a day kayaking on the Chicago River. And then it was then the most awesome thing about it was that inspired them to do a similar program a little bit later last fall in Denver. And so we hope that maybe this will spread. It was a great experience for the kids and for us. I think we all enjoyed it. And so we will be running it again this summer, starting in August. And then we are a site for an industry trial with Cyested, which is the testosterone pen. And currently that's approved for people over 18, but they're doing a trial for under 18. And so we're recruiting and we have our first participants coming in this week. And then Sophia is the genetic counseling student she's actually just graduating, but we're trying to finish her project, which was navigating testosterone therapy, creating a resource for people with Klinefelter syndrome. And she worked with adolescents and young adults to understand what their questions were about how to give testosterone and all the practical aspects of this. And so she for participants to help give us some feedback on the guide that she's created and see what additional improvement is needed. So I thank you very much. I'd be happy to talk with anybody about any of this at any time.
Right. Okay. We have Dr. Boyatsi.
You got to get closer.
Dr. Boyatsi from CHOP Children's Hospital of Philadelphia.
Good morning, and thank you for having me. Let me share a little bit some clinical information about our program. Our program is also relatively new, started about 9 years ago. And we see a number of babies who are diagnosed prenatally. Our registry has about 300 families. And most, again, as I said, most of our cases are prenatally diagnosed, so close to 60%. About 20% or so of our cases are picked up during childhood because of either seizures or other neurodevelopmental problems. And of course, we follow these families on an ongoing basis, on a longitudinal basis as they need to. We have a multidisciplinary structure. So this is a little figure of our team. We are 2 pediatric endocrine providers. We hope to add one more. We have a psychologist, but she's not a developmental pediatrician. So if there is further need for referral, we refer to the CHOP system. We have a genetic a very lovely administrative coordinator and a very lovely nurse coordinator who have been, the core of our team, and a social worker who has expertise in this area. In terms of research, we have a registry for the patients that we saw at CHOP. It includes about 300 patients, families, And we use that to look at our outcomes, get our fellows interested and involved, and looking to develop our own prospective studies. And this is a publication from a study that started a job looking at information needs and health needs for our patients. And also Colorado helped us out with this project as well. And finally, we are part of Galaxy. We are part of industry studies, so people who are interested in clinical trials, we are aside. And we're looking forward to working with the rest of the ACRC network investigators. These are some share, manpower and do as much as we can to help out. Thank you so much.
Dr. Oates from Geisinger.
And is okay, great. So I'm Matt Ogens. I'm from Geisinger. So Geisinger, it's one of the largest rural health systems in the country. So it's located in central Pennsylvania, and so I'm primarily, as working in the ACRC as a researcher. And what my research is actually focused on is probably a different slice of the sex chromosome variation population than maybe has been studied before. So my code is a research project at Geisinger, and it's a genetics focused research. Includes over 1 million patients, but 250,000 of those patients have actually been recruited for a genetic research study. And 250,000 people is a lot, and that can give us the power to actually identify large numbers of individuals with sex chromosome variations actually from their genetic data. And so because Geisinger is it allows us to identify individuals who are adults with sex chromosome variations, sort of, in the adult stage of their life. And most of these individuals actually don't have a diagnosis. So we're actually looking at the undiagnosed, slice of that population, and we can actually look at health outcomes. So we use the genetic data, identify these individuals who have sex chromosome variations, and then we actually link that up to their longitudinal healthcare records. And so we can identify, risks or disease outcomes that are occurring, in mid or later, even elderly aspects of their lifespan. So, just an overview of what we're interested in, how we use the My Code cohort. So primarily we're interested in disease risks, primarily later in life. And we want to actually do risk modeling of individuals with sex chromosome variations to sort of improve their outcomes. So we're looking at anything from mental health outcomes all the way to surgical outcomes. And another aspect of it is because we're using this research genetic information to identify a lot of these individuals with sex chromosome variations to adults who were previously unaware. And so we're evaluating that, the use of population screening for sex chromosome variations and getting patient responses, and just seeing how it influences their health later on. But yeah, sex chromosome variations, they've been understudied in later. And then hopefully that will lead to personalized care, for improving their health. So that's what we do at Geisinger.
Right. I want to introduce Claire Harkin, who has come all the way from the UK to speak with us about the London clinic.
I'm glad I wore my flats this morning. Thank you. Okay, hi. So yes, thank you for the introduction. I'm Claire Harkin. I wear a few different hats within the KS community. I'm a board member and research coordinator for the Klinefelter syndrome with the KS clinics, which is based in London. So we have a pediatric clinic, a young person's clinic, and an adults clinic. So I'll explain to you a bit more about what we do there. Okay, so as was seen from the map from Al earlier on, the European side of things with regards to having these multidisciplinary clinics. So we are very fortunate and very privileged to have the clinic that we do in London. Our clinical lead, now Yap, texted me this morning with our latest numbers. So we have 400 patients. They are either patients that we have already seen or patients that are due to be seen by us. So there is a significant need, and we don't yet have the cell-free screening in the UK like you have in the States. So we anticipate that once that comes in, that number and that demand will be a lot more significant. So the clinic runs 4 times a year, for 4 times for adults and 4 times for adolescents. The pediatric clinic just started back in November of last year. So far, we've had 2 clinics, and there is a lot of interest. So we're hoping to run a second clinic in November time. We have the most amazing team, like all of the ACRC clinics of fantastic professionals who are specialists in XXY. So we have specialists in neurology, genetics, endocrinology, psychosexual medicine, psychology, which includes educational psychology, clinical psychology. We also have a trainee psychotherapeutic children's counsellor. That's where I'll be joining the team professionally, hopefully next year. We also have psychiatrists looking at neurodisability and gender identity specialists. We have plastic surgery as part of the team, fertility, and embryology. So I just want to show you a picture of all the amazing people, all so lovely. And they all do this pro bono. So none of these professionals. So what does it involve coming to the clinic? So we call it like a one-stop clinic shop. So we have rooms for each of the patients and their families. So when they arrive to the clinic, they get escorted to a room where they'll be for the next 2 to 2.5 hours. Members of the team, usually in pairs, will come and visit the families or the individuals, and talk to them about, what they've come in, if there's any particular challenges they're experiencing, and just to do some other sort of exams, etc. We have a nurse specialist who does the coordination of everything that happens at the visit. So once individuals leave, it's not a case that they just get dropped, but that information is then fed into their primary care physicians, so that they're able to access locally the support that they need. We also have members of the Klinefelter Syndrome Association. So that's me or one of my colleagues. And we go in and we talk to the families and the individuals, and we explain what support's available outside of the clinic. I always talk to them about AXYS, because I'm also an AXYS helpline volunteer. Like I said, many hats, and KSA, and we talk about other that can support, especially if there are young people with special educational needs, if there's any neurodivergence. So we're able to offer that support holistically. So that is that. So we also do research and development at the clinic as well. So similar to what's happening in Philadelphia, we have a REDCap database. So we're able to research on challenges that are presented to the KS community and how we can help with that via treatment and support. We also have just had added the National KS Biobank, which is really exciting. So we collect and store cells and tissue, so that's suitable for different ways of or different types of research. And we also have the KS Passport, which is a comprehensive guide for families. On our website, there are some elements that are probably more applicable to the UK, but that's just a small proportion. it's something that might be beneficial to those of you in this room. It can be given to primary care physicians. It can be given to those supporting people in education or in employment. And it just kind of gives an indication of what to expect across the lifespan and how support can be implemented. So there. Thank you.
Thanks.
Yes, it is. Yeah. Sorry, on the
Oh.
website. Yes, it is. So the slides will be going after.
Yes. Yeah. All right. All right. Yes. I think Dr. Tartaglia doesn't really need any introduction, but she is going to speak about the Extraordinary Kids Clinic, which of course established the model for this.
Thank you. Well, I'm excited to tell you about our clinic, but I'm also just so thrilled to hear about all the activities of the other clinics and how much they're growing, and like the Chicago efforts to really start some interventions for these kids in terms of the camp, and the Geisinger efforts to understand the experiences of the undiagnosed population with such a powerful database. All of the clinics do such great work. And so I'm really excited to see the momentum building from all team in Colorado. Little bit about all of our team members who are amazing. Basically, our clinic has many different models, but we do multidisciplinary evaluations that go anywhere from just a one-day or single clinic appointment with one of our specialists to a 3-day evaluation with all of our specialists. And so it's really an amazing, awesome team. Since July of 2020, we've had over patients. If we count everyone, we can only go back and really search, and we should have kept better records, but we've definitely had over 1,000 patients in the course of our existence since 2007. The clinic was really motivated by the XXYY families, which is when I started in this field, was working with told me from all over the world was that there really were not very many professionals at all who knew anything about X and Y variation, about XXYY. And then that was very clear from working with the other variations as well. The parents were the experts. The parents had to teach the professionals. Many professionals were very nice. Sometimes endocrinologists knew about the conditions, but there were not educators, psychologists, speech therapists, anyone else who knew anything. And then there was no one who was pulling it all together. So they inspired the formation of the first Extraordinary Kids Clinic. Little small text on here, but in general, our idea is that we have all the different specialists that we need to take care of all the different areas of risk that can happen in the different variations. I'm the leader with developmental pediatrics. We have child psychology that looks at the social emotional aspect, and pediatric neuropsychology that looks at the cognitive learning and executive function differences. We have speech and OT who can help with the different areas of needs there. Oops. We have pediatric endocrinology led by Dr. Davis, and then we have great support in our nursing and social work. We have a lot of different models of where we put people in. So Susan Howell, who's the heart of our program, and she talks to all the families and figures out what they need and who would be the best people to be seen. She also does a lot of prenatal counseling on her own, and then started and helped us build this really fun new model that we call the baby clinic, where it is where she is seeing them for genetic counseling with all the new babies. And then I see them for the developmental assessments. Dr. Davis sees them for all the medical pieces. And we get to see 3 new little babies in a morning, and it's really super fun. done. Those infants are then followed with another member of our team, Sierra Gurley's, who's here now, and she's a PA with us, who's been an awesome addition, and then another psychologist, Apika, who then does developmental follow-up periodically through the first few years of life. So that's very cool. We also have another model in our clinic that is just for the adolescents who are being followed regularly with Dr. Davis and myself for testosterone management, and then for any of the psychopharm management that I do, treating ADHD and health perspective. So we have a lot of different types of appointments, and Susan is the expert at figuring out where everyone goes. The idea is to meet as a team and really talk about all the different findings that we have from all the different evaluations, so we can really put it all together and give feedback that's informed by communication between providers. We also have 3 other really important missions, right, that we all have in academic worlds, but that we, want to contribute to research, we want to do great education, and we want to work on support and advocacy. And these are some of our, I think working with families is obviously very impactful and important to us, but being able to educate new professionals who are going into all of these different fields and really super important to us as well, because it spreads the knowledge, right? So even one pediatric resident who comes through our clinic during their developmental pediatrics rotation then goes forward to whatever specialty they're going into with the knowledge and knowing about ACRC and the different clinics and areas of expertise, and having a little bit of knowledge. But so we are very proud to be teaching about all of these things. Dr. Davis and Alexa, who are here, Dr. Davis started an awesome summer internship program where we have anywhere from 6 to sometimes even up to 11 interns come through the summer. They're in all different fields, and they're matched up with different mentors in our program, and even now in other programs around the country. And they each have a research project where they're learning about clinical research in X and Y variations. And then we have a big expo at the end of the summer where everyone presents. And it's been a really cool way to really stimulate interest in young professionals in clinical research and in continuing on with this area of care. And so we're very excited about that program. Work on educational materials for families. We just published a great new book led by Susan and Kayla Mollison, who are here, on what to do and when you're expecting a new baby with XXY. And so this is a really nice resource now available on Amazon, and people are able to access this from around the world. And then we've also published books in the past, children's books, talking about the experience and being able to communicate the diagnosis to kids. And we have a really active Facebook page now that, again, Susan and Kayla have been really working to make sure all of the information and products of our clinic are out there. So our advocacy efforts and collaborations with AXYS, with the XXYY project, with Living with XXY, and then with other international groups and leaders is really been amazing as well. And this is our little onesie we give for the baby study that says, did anyone say extraordinary? So, thank you.
Many of you have already been to NIH. It's one of the longest running research projects. I want to introduce Dr. Armin Rosnahan. He'll talk about the current large-scale study that's being done.
Thank you very much. So exciting to be here, really thrilling to see all the work that's growing within the field and to be here with you all. So I'm Armin Razanahan, I'm a child psychiatrist, and I lead the current phase of the NIMH intramural study on XY variation. So as you were just hearing, this study's been running since the 90s. The first stage was initiated phase since about 2015. We've seen 250 families so far, the individuals with the XY variations and their family members, and individuals who don't have XY variations as comparison groups. We began with XYY, then saw XXY, and we're currently in our trisomy X phase. And we're based here just outside Washington, D.C. And all the work happens in this building, the NIH Clinical Center. And here are some members of the team. I haven't managed to include everyone, but we have psychiatric nurse practitioners on the team. We have developmental psychologists. Sienna Mollistuan and Shara Raymer are here, so you'll be getting a chance to hear from some of their about some of their work later. And then we also collaborate with other medical teams within the clinical center as needed. So we have genetic counselors who work with us and pediatric endocrinologists. So that's the clinical team. And then there's a sort of research team that works with them that includes neuroscientists, molecular biologists who work with cells, and computational experts that help handle some of the data that come out of the protocol. So our broad goal is to better understand XY variation effects on neurodevelopment so we can better address families' questions and needs. And the way we do this is that families come to the NIH Clinical Center for 2 days. We fly them in and put them up in a hotel. And then in those 2 days, the family come through and undergo detailed assessments of things like autism, mental health, cognitive assessments. And we also get brain scans and blood tests. And is a detailed clinical report. So all the clinicians sit together regularly and we discuss each young person who comes through the clinic, and together we formulate a detailed report of what's happening with that young person, their strengths, the family. And we hope those reports enable families to kind of leverage and access care in their local state. And then the second output from the study are the data that we analyze to try and get a better understanding of how X and Y chromosomes influence cognition, behavior, brain structure, and function in the genome. So I just wanted to end this brief overview with data to address. So how did different XY variations impact mental health? Are there some impacts that are shared, and are there others that come more when you have a Y chromosome or when you have an extra X? Do these impacts vary with age? Which mental health symptoms most seem to impact functioning? And that's interesting because the answer to that question is different from which are most severe. Sometimes the things that are most severe may not actually be the ones that are really causing most difficulty in the population we see, and emphasize the great variability in outcome. And then this variability is a key thing we want to understand, because for families, the question isn't what's the average outcome in an individual with XYY, for example, it's where's my child going to be? And that's all about predicting that variability. So we've been trying to see that. Shara Raymer has a poster on that today. Well, throughout the meeting. And then the final set of questions we try and tackle have to do with mechanism. Can we identify the brain systems and the genetic systems that seem to be conveying the impacts of XY variations on development? So that's a brief overview of who we are, what we're trying to do, and how we do it. Really, really excited to be here. Thrilling to see the burgeoning work in the field, and just looking forward to interacting with you all. Thanks a lot.
I'd like to introduce Dr. Hooman Sadri, who is a reproductive urologist at Wake Forest Medical Center.
Thank you for the introduction. It's great to be here after a few years, and again in a very nice community. My clinic actually is mainly focusing on male reproduction, but that doesn't mean that I don't have connection with other specialties. I mean, we have very, very good connection with pediatric endocrinologists and a lot of primary physicians and some other colleagues that send the patients to my clinic. As of today, actually, I checked, I have around 91 active Klinefelter patients in my clinic, which is a good number for having these patients. On a clinical side, actually, I have different target patients. I see the patients, they come to me that they and the genetics shows Klinefelter, ask me what to do. I have pregnant women, they come to me and say they carry a pregnant, the Klinefelter boy, and they ask me what to do. And of course, I see different ages of Klinefelters as I have, both pediatric and adult appointment. And of course, I tell the first two groups that nothing, just you will have a great, son, and need some help, and some, like everybody else, that they need some help, and we will help him. For other patients, it depends on what they're looking. I help them. A lot of pediatric endocrinologists, when they talk to the patients and family, they have interest on fertility preservation for the future. They prefer to send the patients to me to manage even the testosterone treatment for them instead of they do. They're very nice, and we actually work very closely. Then the services provided could be a consultation. It could be, the management of the puberty, and also help them to go through the fertility journey if they need. And there should be a medical treatment or surgical intervention to help them, as we have a very active testosterone treatment is, very important for many of these patients that they stay connected with our clinic. I see patients at 6 different locations in North Carolina, United States, in 3 different cities, depending on, where the patients are more comfortable. On the research side, I have a research lab focusing mainly on male reproduction, but one of the specific arms and important groups that we are focusing are Klinefelters. When I moved actually to Wake Forest University almost 13 years ago, one of the first things I did, I established a clinical, experimental banking for mainly for the pediatric cancer patients before going through the chemo radiation. But in addition, the Klinefelters, for some other reason, that they are going to be a high risk as part of this banking. So far, we have over 200 patients actually in this banking system, mainly cancer patients, but we have also Klinefelter patients. And I'm talking about this more in the afternoon in my, talk on fertility. The other exciting works from our group is actually we developed a 3-dimensional human testicular organoid system, which is an active patent right now. And it's, as far as I know, it's the most advanced organoid system from human testis that can be used not only for clinical use, for a lot of, research indications. We create the organoid after propagating this biopsy cells that we have from the patients, and then we put them in a special system to go from a diploid cells to the haploid cells, which means cells that they have half a chromosome like a sperm. And so far, we have been able to go through the cells with the half a chromosome, like as you can see, the cells that have 1X, 118, or 1Y and 118. Of course, we have to prove that we can use this one for fertilizing the eggs. Because of that, actually, we have another clinical trials going on, not only for this patient, also for other group of patients that they only have the round spermatid, the same concept that we actually are developing a method of round spermatid injection instead of sperm injection. And this is a ongoing, research that we are working on that. If you want to contact me for being a patient or some consult, they all have it. And they don't call me, they text me, you can use it, or email me and I can direct you to the right person. For more information, you can scan the barcode and get more information in my website. Thank you. Have a good day.
I want to introduce Dr. David Wong, who is a child and adolescent psychiatrist with Stanford.
It's such a pleasure to be here. Thank you. I'm representing Northern California, Stanford University School of Medicine, where I am a child and adolescent psychiatrist. Similar to a lot of the other programs here, we have a clinical care model that encompasses a number of specialties. Really, the medical home at Stanford for anyone with an X and Y variation tends to be in pediatric endocrinology. So all of our pediatric endocrinologists are familiar with these conditions. Currently, the lead that we have who's focusing in this area is Dr. Diane Stafford, who's the vice chair of that division, and very supportive of work in this area. We also have a long history of psychiatric involvement, and that's a number of our child psychiatrists have work in this area. Many of you who've been in the field may know Dr. Alan Reese, who's been doing this work for decades now, as well as myself. And then we have Dr. Gisela Sandoval as well. In addition to the endocrine and psychiatry services, which are sort of the core of the services that we provide at Stanford, we do have a neuropsychologist who also does standard therapy as well as testing, Dr. Tracy Jordan. We have a urologist who does double duty also for all the reproductive endocrine work, which is Dr. Eisenberg, as well as various other services, including genetics and cardiology. One of the things for really having a coordinated single-day multidisciplinary clinic. Ours is still a referral care model, but we're hoping to move more in the direction of doing a multidisciplinary clinic going forward. Overall, the services that we provide encompasses all of the X and Y variations, though most of the patients we tend to see either have XXY or Turner syndrome. And the way the system is set up, at least at our institution, it really is focused between either young adults and children, which is on our side of the services at Lucile Packard Children's Hospital. So we do see everyone from it's up to 25 years. And as I mentioned, we are hoping to get some traction with getting a multidisciplinary clinic established. So on the research side, we have a very long history, really started studies for a very long time. In fact, published some of the earliest MRI studies in this condition, really examining the relationship between the genetic conditions and brain phenotypes and behavior. Our pediatric endocrinology department is also a site in several clinical trials, particularly looking at hormone treatment interventions. And we are part of the broader Galaxy Registry and RDCRN, if it's going to be funded with Doctors Tartaglia and Davis. I'm sure they'll talk about it more later. I do want to talk about some of the recent data that's come out of the study. And I say that because AXYS has been just an absolutely incredible partner in recruitment and supporting research studies across academic institutions across the country. And there may be families here who participated in that study as well. So the most recent study that was concluded was called Brain, Genes, and Puberty. So looking very specifically at boys with Klinefelter syndrome as they're going through this adolescent period. And we successfully recruited over 100 subjects, including 60 boys roughly who had Klinefelter syndrome. And just to highlight a few of these, it was led by Drs. Ross at Nemours and Drs. Reese, who you guys may know both of them. They've been doing a lot of the most seminal research in this area. And then one of our senior scientists, Dr. Lara Foland Ross. So there's several neuroimaging studies that came out, including looking at fMRI tasks, executive functioning, and how that relates to brain activation. And just as a real highlight, some of the findings are that there are executive functioning differences that relate to brain activation, having lower testicular volume or lower levels of testosterone. Similarly, with face emotion tasks and how to identify particularly negative emotion faces like anger and fear, similar patterns where there's correlations with testosterone level. And then excitingly, looking at connectivity between different brain regions, there's a study that came out where you can classify those images using machine learning strategies, and that might hold some promise in the future for using methods can accurately classify to a certain degree using these brain connectivity patterns, the degree of impairment on some of these cognitive dimensions. So that's been pretty exciting as well. On the behavioral and mental health side, just looking at some of these outcomes, in adolescence, we are finding there are a lot of the same domains that are affected and have been well established in Klinefelter syndrome around academic achievement, some of the cognitive domains that are affected around language, executive function. We're also finding, again, to be effective. And when you compare kids who are in the prepubertal stage versus in the pubertal stage, it tends to seem more prominent for the kids who are going through puberty or are past puberty. So an interesting developmental kind of dynamic there. So again, we're looking forward to continue to expand our clinical services and ongoing work in the research area. Please don't hesitate to drop by and ask me any questions. I'll be talking about transitional age youth. So really the transition between adolescence and young adulthood later today if you have any questions.
Our final presentation is going to be by Sharon Close of the Emory Clinic. We're very grateful to Emory for hosting us at this wonderful site again. Sharon.
Thank you, everybody. I think I'm here to tie this up in a bow for all of us, and I'm happy to. So we do this. Okay, so our clinic operates 2 times a month on the 1st and 3rd Fridays of the month. And why do we do Fridays? Because nobody else wants to work on Fridays. So we decided that it would be a good time for us. Who's sitting in the front. We see all sex chromosome variations. There is, however, we have a unique unique patient base of about 450 patients. And so we have, with only 2 clinicians in the clinic itself, we have a huge waiting list of almost 18 months old. So some of our efforts, especially at research, have been kind of light because we are in such clinical demand and we draw regionally from all of the states in the Southeast. But we do have priority in scheduling in case of cancellations. And so we're actively trying to pull people in. And our clinical focus is the primary developmental evaluation. We have genetic counselors, and we have also do the multidisciplinary key referrals within the Emory system. But because we're regional, sometimes we have specialists within their local areas. So we have a clinical neuropsychologist, pediatric endocrinologist, and a reproductive specialist as well. We do, however, try to focus beyond clinical too. And we're associated with the School of Medicine and the Department of Human Genetics. We host medical student rotations, genetic counseling student rotations. I'm a nurse practitioner about X and Y chromosome variations. Thank you. Nobody. We also are very active in our Southeast Resource and Support Group. That is actually, there's a parent liaison who's Dorothy Booth, who is there she is right over there. We work very closely with Dorothy to keep our families together and tight, which is a job because we also, like I said before, we're kind of regional. So, I think one of the most important things we do is that we do internal Emory clinical staff training and education, as well as policy and advocacy. So what do we do in terms of staff education? We want everyone from the time they walk out of their doors at their home, we have to recognize what a patient and family's expectations are for a visit. So we want to be sure when they walk in our door that everyone, including the receiving person, the business person, the nurses, the medical assistants, everybody has somewhat of an understanding of what sex chromosome variations are, but also a special understanding on the front end of their parental and also patient concerns about the visit. And so we try to train our staff to have them recognize that families come to us with variations of hope and fear and confusion and searching for answers and the need for acknowledgement. And we want to surround that family not only with clinical resources, but also knowing that they have found a clinical home with us. So they search for a medical home base, and we hope to be that for the sex chromosome variation. With is dissemination and awareness. How many times have we heard, nobody knows about this? I'm teaching my pediatrician. My community doesn't understand. My school doesn't care. They don't understand what this is. And so make no mistake, now that the Federal Department of Education is being dissolved and all of these things are going to the state, I'm sending out a call to action to you all to really begin to educate your state legislators and your state new policies and new protocols in schools about what therapeutic interventions we might have currently or hopefully now with all these studies in the future. And so our goal is we show up down at the Hill, even though we don't have a hill in Atlanta, but we try to leave a lasting impression. When Betsy Holland, who is my representative, she sees my face, she knows why I'm there, and I can tell her what's currently representative, it really matters. So we are actively engaged in policy initiatives by increasing awareness. The month of May is dedicated as the X and Y chromosome variation month. Every single year, we bring our families and we stand there with our legislators. We hope to do this by spreading awareness. This is our former governor, Nathan Deal. Our current governor is Brian Kemp. And so we bring them so that our legislators can see the faces of the children, the faces of the adults. We have a request. They are educated about what sex chromosome variations are. So that's my biggest call to you. Learn who your legislators are at the state level and go to them, introduce your children to them, and let it be known that you are a person who is going to be called to action with some of these new educational policies. And aside from that, we try to feed the extraordinary study in Galaxy, and we have great hopes for the new NASCAR study that is emerging. And that is Emory. I want to welcome you to Atlanta. Hope you get some fried green tomatoes and some peach pie.
I spoke briefly about the stipends. I spoke briefly about the stipends. I encourage you to apply. Again, we've only dispersed about half the available. neglected. The XXY project, who's headed by the vice chair of our board, Gail Decker, also has a stipend of up to $750 to cover reimbursement for travel expenses to an ACRC clinic. So with that, we're going to take a 10-minute break. If everybody be back in 10 minutes, we have Dr. Shanlee Davis that's going to be speaking.
Okay. All right. We are ready to go. I'm going to give you very short introduction. Dr. Shanlee Davis is a pediatric endocrinologist, and she's a physician scientist in Colorado. She has been the principal investigator on the GALAXY study, which is a longitudinal research initiative that is aimed at advancing knowledge about individuals with X and Y variations. She's going to be speaking about the findings. Alexa Carl is the program manager for the GALAXY study, and I'm going to let them get started.
Excellent. All right. Hopefully our slides work. So we just did introductions. And I just want to also acknowledge that this is, we're up here representing the GALAXY Registry, but this is actually a collaboration with AXYS and the XXYY project, as well as a whole bunch of people in this room and throughout the country. And so we're going to give you the overview, but there are a lot of others involved. All right. So our goal is really to get you guys excited and enthusiastic about GALAXY. Hopefully you will be as excited as we are at the end. We'll go over what GALAXY is, why it's important, how we're doing so far, where we're going, and who we hope to engage next. All right. So as was already mentioned by Ginny, GALAXY is a multi-center clinical data registry and biorepository for individuals with all or any X and Y chromosome variations. We hope to be able to look at clinical outcomes, determine best clinical practices, and really support future research and quality improvement efforts in this population that will ultimately improve all of the outcomes for individuals living with these X and Y variations. All right, so GALAXY is a joint community venture. As I mentioned, this is not a typical research study. It involves individuals with X and Y variations, their parents and or partners, or their family advocates or friends, advocacy organizations, including AXYS, clinicians, and researchers. Okay, that wasn't supposed to go up like that. And then the second part is the idea is that we are working together to collect and store data, and what data this is or information this is includes health records, contact information so that we can have individuals for new studies, for example. We include survey responses and then biospecimens as well. And why? It's to study meaningful things and to make sure that we're asking the right questions in the right way, prioritizing resources to get results, and having an ongoing dialogue between community members. So this is a really busy slide, but this is the overall kind of schema of our GALAXY registry. And so up on top here, you can see that it starts with the steering committee. Can everyone that's on the GALAXY steering committee that's in the room please stand up so that people can see who you are? So thank you. These individuals have been donating their time and expertise for the past 3 years at this point, actually. We meet once a month, typically, for an hour on Zoom. And the steering committee has representatives from all of those different groups that we talked about. So X and Y affected individuals, parents or other support people, clinicians, and researchers. So they're representing different stakeholder groups. And this group, the steering committee's job is to really establish the oversight of the GALAXY project as a whole, establish the priorities, approve all of the documents like what are we doing? What does this protocol look like? Where are we going from here? If someone wants to do a new study, for example, the steering committee has the oversight of all of that. We then have down in the green over here, the clinic sites. And so this initially started just at Children's Hospital Colorado with the idea that it was going to be built at other clinics in the ACRC. And we are now, over the last year, really expanding into those other clinics. And they're actually starting to enroll individuals with these conditions at other sites now as well. On this side here, really the most important part, individuals with X and Y conditions. And we really want them to not just be people that we're studying in this, but really be a part of this process. And part of that, Alexa will go over a little bit of the consent, but when you elect to be part of the study or you enroll into the study, you get to really choose your level of involvement with a lot of different options, from as minimal as just allowing us to use clinical records for research purposes. So you really have no ongoing or needed additional things to do, versus being involved in a whole lot of other ways. And then finally, we are down at the University of Colorado / Children's Hospital Colorado, the lead data coordinating center. And so we do all of the logistics behind the scenes to run the REDCap database, do data analyses, all of the training and onboarding for all of the different sites, et cetera. All right, so when we started the Galaxy Registry, we really, and this is a constant balance and figuring out where we should put our priorities. So most research studies, as you probably know, really focus on specific goals. They have targeted data collection, a pretty limited time and scope. So you might participate in a study that is, 1 year or one time frame. And there's clear products at the end. The Galaxy Registry is that plus. So we have that as a small part of the Galaxy Registry, but really it's focusing on the infrastructure that is going to be able to collect broad data collection, longitudinal emphasis, and really be a resource for future research that can be conducted. And so finding a balance between how much effort we put into, the targeted individual goals so that we can actually be giving products back to the community versus the infrastructure is something that is a little bit different between this and other research studies. Oh, this is still me too. Okay. So why is Galaxy important? Well, Galaxy is important because X and Y chromosomes, chromosome variations, as everyone in this room knows, are under-recognized, underdiagnosed, and understudied, and we need to change that. And this is the opportunity. This is the time to really do that. Individually, these conditions are still a rare disease, or individually rare diseases, and so there's limitations with how much data and knowledge is out there on rare disease conditions, and bringing people together in numbers with a registry has a lot more power. There's a lot of potential for organized data collection and generating a repository. And also, ultimately, we want to be able to do intervention studies, and this is an infrastructure to be able to support that. All right, Alexa's going to talk about where we are at so far.
Thank you. You're going to hear from her again later. I also want to say thank you to everyone who sang me happy birthday. Nothing like starting the year with 200 people staring at you. That was amazing. Orchestrated by your boss. So I love that for me. So I'm going to talk about how we are doing so far. A little bit of a timeline here in terms of Galaxy from its inception or even prior to that up until now. So prior to starting Galaxy, we actually had another database called Insights that is for Turner syndrome specifically that we used as a model of what Galaxy could look like. We then received some seed funding from AXYS, the XXYY project, and Living with XXY to really get this project started. And in April of 2022, we finally got regulatory approval to begin. And then in June of that year, enrolled our first participant at Children's Hospital Colorado. A few months later in August, we enrolled our first participant outside of Children's Hospital. And then in October, we had our first steering committee meeting, as Shanlee talked about. Then just this May of 2020, over time. So this graph shows the kind of number of participants who had enrolled, which is slightly different than those who had consented, because enrollment means they consented and we verified their eligibility by reviewing their genetic test. And so we have a total of 490, so close to that 500 mark here. And over time, you can see the steady increase in enrollment as we've continued to go and add more sites. Our biggest group is the Klinefelter group, or XXY. That's in the green color. XYY is the orange. Trisomy X is yellow. XXYY is blue, and other is gray, which I say because I have many slides with that exact same color scheme. So that's kind of where we are right now. We can also look at our participants, not just by condition, but by where they come from. So this graph shows the number of participants who have enrolled by their state of residence. So the darker the blue, the more participants from that state. Obviously in Colorado, we have the most, which makes sense. We've been enrolling for the longest, but we also have a number of folks from other states such as California, Texas, and New York. I also want to point you to the Galaxy dashboard. This is a live summary of information on participants who are in the study. You can get to it from this QR code as well as from our website, galaxyregistry.org. This is a screenshot of that website. You can also enroll in the study from there, as well as get to the public data dashboard. There's a thing at the end with all my QR codes because I have a lot. So the slide at the very end has all of mine. So if you miss them, do not worry, it will come back up. This is a screenshot of the data dashboard, so you can kind of see some general demographic information. We have mostly males in the study right now. In terms of race and ethnicity, we have mostly white individuals. That's that biggest line. It's a little hard to see, but the next biggest group is the Hispanic or Latinx group. In terms of insurance status, that's kind of what we use as a proxy for socioeconomic status. We have mostly privately insured individuals, with the next biggest group being our Medicare or Medicaid. And I'll pass it back over to Dr. Davis.
You guys don't have to clap in between each of us. We go back and forth a lot. All right, so we've had a lot of great success thus far, and this is some of the kind of more scholarly projects that have come out of Galaxy in just the short time that we have been up and running. So we've had 3 papers. As of this morning, the Galaxy Methods paper was accepted. So we now have 3 published manuscripts that, again, we'll be able to view on the QR codes coming up, and we're going to talk more in detail about these studies on the next slides. We have a couple of abstracts that have been presented at different academic conferences, and we are currently have one ongoing project from a summer intern that is working on the XXYY individuals specifically in the registry. So, oh, this is me too. Okay, so we're going to talk about the first paper was research priorities of individuals and families with sex chromosome aneuploidies. And this was a survey that went out from the Galaxy registry as well as from the Insights registry. And so it did include Turner syndrome as well. I'm just going to present the X and Y variations that are not Turner syndrome here. The goal of this survey was to determine health areas of the highest research priority in the SCA community and explore differences when we look at different SCA groups, for example, or whether or not the individual was responding for themselves as a self-advocate or a parent or a guardian was responding. And so those were the overall objectives. As far as who answered this survey, we had 17 individuals with XXX or their representatives. And you can see in here how that broke down. So 3 were self-respondents and 14 were parents. And then across the different X and Y chromosome variations. So starting off with behavioral health priorities, just to orient you, down at the bottom here is it goes from 0 to 100, and all of the individuals that were filling out the survey could say how important is it for us to do research on X, Y, or Z, that's the topic that we're talking about. And then they can rank it anywhere from 0, being this is not a priority at all, don't focus on this, to 100, which is this is definitely the top priority, we should focus on this. I know that it might be a little challenging to see, but this top one here is learning disabilities or learning differences or academic concerns. There was a little bit longer, but for this, we just shortened it. And this was the highest priority when you look at the whole group overall, but there were some differences between the different X and Y conditions. The bars here, I should say, sorry, are the median line. So the 50th percentile line is the line in the middle of the bar. And then the bar, the whole bar goes from the 25th percentile to the 75th percentile is what we're looking at. So you can kind of see where everyone is falling. This has been published, and I'm not going to go into the details. I'm just showing you that overall we were able to really look at individually priorities from a behavioral health perspective, a physical health perspective, and other research priorities that might not fall into those groups, and see overall what the community is asking for, and then more targeted specifically on these individual variations to see some variability among them. All right, Alexa.
This is the paper that was just accepted this morning. I was planning to say this is just a preprint. It hasn't been accepted yet, but that is actually no longer true. So I'm going to present some data from this publication that we kind of have dubbed the methods paper. So it is the rationale, design, and methods for the registry, as well as some preliminary results. This slide, I'm going to thank Kayla Mollison. She presented this at the 2024 Western Medical Research Conference, and I stole her slide. Thank you. So this looks a little bit further at some of the demographic information of our participants who are in the study so far. And we wanted to see how many folks we have who are typically underrepresented in clinical research, because we want this registry to be representative of every or as many people as possible with sex chromosome variations. And so underrepresented does not just mean in relation to race or ethnicity, but it also includes primary language being something other than English, having a low socioeconomic status or lack of health insurance, as well as gender identity. And so we categorized individuals as either from a represented group or an underrepresented group. And we had just about 40 participants who were somehow underrepresented in research, with 70% of those being a member of just a single underrepresented group and 30 being a member of multiple underrepresented groups, plural. The next couple of slides are about our preliminary information on diagnostic history. So to orient you to these graphs, I'm going to kind of go over. So the y-axis is the percent of participants from 0 to 100. The bright blue is individuals who were diagnosed prenatally with a sex chromosome variation, versus the orange is those who were diagnosed postnatally or after birth. And this breaks it down by karyotype group. So you can see in our trisomies, XXY, XYY, and trisomy X, that it's about half and half in our study, prenatal versus postnatal diagnosis, versus for our tetrasomies, so XXYY as well as XXXY, it's mostly individuals who were diagnosed postnatally. And then our other category is kind of other variations that are smaller groups so far, and those are mostly diagnosed prenatally in Galaxy. These are similar, looking at the type of genetic test that was used to diagnose the sex chromosome variation. So a FISH and a karyotype are most often used in our prenatal group. The other is a very small, there's only about 5 or 6 in there. It's like kind of panels. And then microarray and gene sequencing are more often used for our postnatal diagnoses. On the graph on the right, you can see the reason for genetic test by the timing of diagnosis, which is starkly different in our pre and postnatal. So prenatal individuals are overwhelmingly being diagnosed for incidental reasons, so not secondary to any symptom or cause, versus our postnatal is more often diagnosed secondary to some sort of symptom or indication. I want to dive into that a little bit further. So this is specific for our prenatal diagnoses, the reason for the genetic testing or the indication for the original test. So we have 139 individuals in this group, 40% of which were diagnosed or had a genetic testing due to advanced maternal age, which is defined as 35 or older at the time of delivery. And then 27% due to routine or elective screening. So this is things like knowing the gender of the baby. And both of those are considered incidental findings. Versus our postnatal diagnoses, many more potential indications for genetic testing here. This represents 162 participants, and it's a little bit hard to see, but the most common reasons for genetic testing in this category were developmental delays, learning or behavioral concerns, excluding autism, and dysmorphic physical features. And then lastly, I also borrowed this slide from Alyssa Keller, who is one of our students doing the internship program that Dr. Tartaglia talked about earlier. She presented this just this January at the Western Medical Research Conference, looking at prenatal health in pregnancies affected by a sex chromosome aneuploidy. So you can see the bars with the kind of stripes on them were the percent of pregnancies affected by a maternal complication. So that would be things like gestational diabetes, hypertension, or preterm labor. And then the solid line is the percent in each karyotype group that were affected by at least one fetal complication. So that would be things like poor fetal growth, high or low amniotic fluid, or issues noted on an ultrasound. So overall, you can see that at least 25% in each group were affected by a maternal complication during that pregnancy, and at least 31% were affected by a fetal complication during that pregnancy.
Okay, and then finally, the last paper that has been published with using Galaxy infrastructure was by our clinical pharmacist, Joanna, who also has a poster, so you can learn more about this at the poster session, but looking at psychotropic medication use in XXYY syndrome. I'm not going to go into the massive details here, but this is looking at age of starting medications from 0 to 30. This was, I should back up a little bit. This was a survey / chart review of individuals, over 100 individuals with XXYY, looking at different medications to treat ADHD, anxiety, depression, mood disorders, et cetera. And so this is the first and really awesome, robust description of experiences with these different medications in this population. And so I encourage you to go check out the poster to hear more. The conclusions of the poster was that these medications are quite common to be used in XXYY, and primarily stimulant ADHD medications were the most used class. And I will skip the rest here. All right, so where are we going from here? So you've heard a couple of mentions of this NASCAR proposal or RDCRN. So I'm going to break that down a little bit for you. So the RDCRN is the Rare Disease Research Network, and this is an NIH program that supports rare disease consortia. So groups of clinics and researchers across the country that are interested in specific study and care of individuals with a group of rare disease conditions. And this comes up for renewal every 5 years for new consortia to join. And we, this past year, we applied as one of the consortium. Our application scored very well. And so we are very excited that for the potential possibility for this to be funded. And this will include, it's really a network of 18 sites across the country that are invested already in taking care of individuals with X and Y chromosome variations or studying those conditions on a research basis. So the network, the NASCAR stands for Network for Advancing Sex Chromosome Aneuploidy Research Readiness. We added an extra R, so it doesn't actually have the exact same spelling as NASCAR. from the perspective of how this relates to Galaxy, project one of this very, very large proposal that was over 1,000 pages submitted to the NIH, project one is longitudinal registries to inform the natural history of sex chromosome aneuploidies. And so this includes Galaxy and Insights, as we mentioned before. So the aims of this project one are, number one, to develop a high yield longitudinal clinical data and biospecimen repository representative of all individuals with SCA, utilizing the foundation of the Insights and Galaxy registries. Number two is to describe the systemic morbidity associated with each SCA across the lifespan. And number three is to determine phenotypic traits that are common among all of the different SCA conditions, as well as those that are unique. So unique to just having two double Y, for example, or unique to having two or more X's. This is a little bit of the history of SCA's research overall. So back in the 1940s to 60s, there was when these conditions were first described, and we had some birth cohort studies. As my default speaker has changed to headphones. I don't know if that matters, but okay. We had birth cohort studies that really have told us a lot about the initial longitudinal natural history of these conditions, but they're now quite old, 50 years old at this point. We've had multiple limited, kind of what I would call limited scope studies. So they're very focused on a particular condition or a particular issue, often cross-sectional, often at a single institution for the next several decades. You may have been exposed to the peer registry, which was an initiative in the 2010 decade that AXYS participated in, that was a start of a registry with a lot of lessons that we were able to learn and really take into developing into that a more mature Galaxy registry that we're talking about today. As part of this, we also hope to do more complex analyses, including looking at the specific contributions of the sex chromosome dosage, so the X chromosome dosage, the Y chromosome dosage, and looking at some unique features of those. And the bottom line is we need thousands of individuals in order to do these more complex analyses, really hundreds in each karyotype group. And so we really want everyone to be represented in this. And I think this is your slide, but
Yet another QR code. I love QR codes. They're so great. So now that we have told you a little bit about who is in the study so far and what we've been able to do, you may have noticed that some of our groups are smaller than others. And we really want to improve recruitment moving forward, especially for those smaller groups, to make sure that Galaxy is representative of everyone or as many people as possible. And so if you have thoughts on that, I would love to hear them. I'm always looking to improve the way that we recruit and talk about this study. And so you can scan this code and there's kind of a short answer survey question basically about ideas for improving moving forward.
all right. We're going to wrap up here with some frequently asked questions. So why is it important or worth it for me to sign up? Hopefully we've convinced you that of all the important reasons, but again, each person with an X and Y variation is unique and we want your story to be represented in this database. And as we mentioned before, these conditions are rare, and the more participants that we have, the more sure that we can be, that we are finding correct associations.
One of the most frequent questions I get when people are signing up for the study is, how do I know that my data is private, or how do you secure my data? So the first, obviously, we follow all federal, state, and university rules, laws, and regulations to protect privacy and store data. We are overseen by a regulatory board called the Colorado Multiple Institutional Review Board. And so they are another check to make sure that we are following all of those rules and regulations. All data is stored in a database called REDCap, which is a HIPAA-compliant, password-protected database that is specifically designed to securely store research information. We also use a study ID system, so each participant is assigned a number, and most people who see the data just see information with that number and not participants' names or things like that. Only individuals approved by the PI, so Dr. Davis, who have completed required training have access to that REDCap database. When we present or publish information, as we have done today, we group the data together and give a summary rather than information about any specific participant. And finally, our sponsors, so the people who pay for the study, do not get access to any identifiable information about our participants.
Okay, so what is the minimum amount you have to do? Sign the consent form online is the minimum, and uploading your genetic test or telling us where your genetic test was done at, so that giving us permission to go and get it for you. I guess this is you. Why? We should have just combined that.
That's okay. Lesson learned. So you might be asking why we actually need to see that genetic test. The only eligibility criteria for Galaxy is a genetically confirmed diagnosis of an X and Y variation. And so before we enter any other data about an individual, we do need to confirm that genetic component there. We also want to know the exact karyotype. So for example, if someone has multiple cell lines, we want to know that. We want to know XXY versus XXYY, that type of thing. And then these genetic tests also contain useful information that I presented earlier, such as the timing of the diagnosis, as well as what symptoms, if any, led to that testing.
All right, so probably the second most important question or frequent question that we get is what do I do if I don't have the genetic test that shows I have an X and Y variation? So as we mentioned, you can sign a release of records telling us where you got the test done and allowing us to reach out to that clinic so that we can get a copy of that as well. We'll accept any sort of genetic test that confirms the X and Y variation. So karyotype is the most common, but it can be other genetic tests as well. And if you don't have a copy of your genetic test results, we think that it's important for your own medical information and for your own records to have that. And so we encourage you to talk to your doctor about ordering this if you really don't have it and it's just not available, like your clinic burned down 50 years ago or something along those lines.
All right. So if you decide to sign up, what is involved? So the first and most basic is giving permission to access those medical records. So the basis of this study is building a longitudinal database of clinical data. And so we want to follow folks over time at all their various clinical visits, labs, or other procedures that you may have had. And so if you sign up at one of our clinic sites, we can pull the data that way. But if you don't, we want to have access to request those records from wherever you are seen. Optionally, you can also join our future studies list. So you're not agreeing to do any additional research. Just if there's a study that you or your child is eligible for, we can contact you and let you know what that study is about. That way you can decide at that point if it's something you would like to participate in. And then another kind of optional thing is that you can complete some surveys for us. So for example, the research priorities data that Dr. Davis shared was from a survey. And medical records only tell part of the story. They're very important, but there's some things that are hard to get out of the medical records or that simply aren't there at all that are still really important for us to know for some of our participants.
All right, and if you're so excited that you want to be more involved, we have the biorepository, as we mentioned earlier. This is only available if you are signing up at one of the clinics, because unfortunately we cannot do remote collection yet at this point. You can choose to be involved in the steering committee or special interest committees. We depend upon volunteers who are invested and willing to lead the future of Galaxy to volunteer their time and participate in these. And so please contact us if you might be interested in serving in that way. If you are a researcher and say, you know, we could really use the data that are in Galaxy or that could be obtained from Galaxy, there is a template available on our website to submit a research proposal, and the steering committee will then review to determine to make sure that it is an appropriate use of these resources. And then finally, a big plug that we really desperately need financial resources in order to continue Galaxy at this point. So if you know of any donors or organizations who may be interested in supporting this work, or if you yourself might be able to financially support this work, we would definitely welcome and accept all contributions of all sizes, and they can be anonymous, or we can acknowledge you as well. And so let us know certainly if you are interested in hearing more about that.
And the last frequently asked question, which I get all the time, is that you started in 2022. I do not remember what I ate for breakfast this morning. How do I remember if I signed up for this registry already? And we are happy to help check that for you. Myself, as well as some of our other research coordinators, are hanging around today and throughout the conference, and we can go ahead and check if you have already enrolled in the study. We need your name and your birth date, or your child's name and birth date, to check that out. You also feel free to email us if you don't have time to stop by our table. Our email is very easy to remember. It's just galaxy@ucdenver.edu.
All right. So in conclusion, Galaxy is a community partnership that is already generating important information for X and Y variations, but we're just getting started, and there are lots of exciting opportunities that we hope you will join us for. And with that, this is the last QR code. Sign up online. This QR code or redcap.link/galaxy-consent. And again, we have a table right outside that we're happy to help with as well. This is part of our team, the Galaxy Steering Committee members who we mentioned before, which we should get a picture while we're here as well, the Galaxy Steering Committee members, I should say. And then these are finally all of the QR codes while we can take some questions.